quote the session as well. Yeah. So her research interests focus on maternal and the child health, respectful maternal care, infection prevention, and the health system strengthening with expertise in qualitative and the mixed methods studies. Brenda has actively contributed to national health initiatives, including the review of Zambia National Health Strategic Plan, midwifery training framework as well. So she is passionate about advancing evidence-based practice to improve maternal and neonatal outcomes in Zambia and the broader region. And for today's webinar, she will be our moderator, leading it from the beginning to end. Welcome, Brenda Azul. The floor is yours to proceed. Thank you so much.
Thank you so much, Juliet. Thank you so much, Julius, sorry. And good afternoon, everyone. Like it has been alluded to, you are all welcome to this webinar, very important webinar, where we learn and share information about improving maternal and child health issues. So our programming will be as follows. There will be opening remarks, and then the webinar objectives, introduction for panelists, panel discussion presentations, and we'll have question and answers. So please just take note of any concerns or questions that you're going to have or contributions. You'll be given time to come and pose questions. And then after the question and answer session, we will move to the next steps, and then we'll wind up with a vote of thanks within the 90 minutes that is given to this webinar. Okay, so at this point in time, I would like to call upon Madam Seventa to give us the opening remarks.
Okay, thank you, Brenda, for the introduction. I am Sebentile Mieni, and I am delighted to welcome you all to today this webinar on combating maternal and neonatal mortality using evidence-based approaches. Maternal and neonatal mortality, it remains amongst the most urgent public health challenges in our region and globally. And every day we lose lives, mainly on preventable causes of death, which could be prevented if they would be attended to timely with quality and equitable care. So we all know that we're working towards the SDG 3 and all the other SDGs. So this webinar today, it brings together the experts that are there. Together with the participants, we acknowledge that you are also experts in the area, and we also have implementers that are there. So all the lessons that will be learned today, we believe that it will bring about practical strategies that will provide maybe evidence that we will come about that will be implemented and we apply after this. So in short, we are grateful on behalf of ECSA to the panelists that have agreed to share their expertise and knowledge, and we're also grateful to the participants for making time to participate in this webinar. So your diverse expertise and knowledge, they are all welcome to bring the solution that is data-driven and that will be sustainable. So we're looking forward to an engaged dialogue and knowledge sharing in this webinar. So once again, thank you very much for joining us in this webinar. Thank you very much.
Thank you so much, Madam, for those encouraging words. So quickly, we will look at the webinar objectives. The first one is innovations and evidence-based clinical practices. The next one is community-centered and culturally responsive interventions and strengthening health systems for maternal and neonatal survival. So when you look at the objectives that we have, they all are directed to us as midwives to work using evidence-based locally. So our panelists for today, the first panelist that we have is Dr. Benjamin Kamala, who's going to take us through in the innovations and evidence-based clinical practice. Dr. Benjamin is currently leading the Safer Beds Bundle of Care project, which is being implemented in over 150 hospitals across 5 regions in Tanzania, with the goal of significantly reducing perinatal morbidity and mortality. This project builds on his PhD research, where he evaluates an innovative fetal heart rate monitoring device designed to improve perinatal outcomes. Through this work, Dr. Kamara is driving large-scale improvements in maternal and newborn care by introducing evidence-based practices, improving clinical skills, and strengthening health systems responses to birth complications. His leadership in this project reflects his continued commitment to advancing maternal and neonatal health in Tanzania and beyond. Ladies and gentlemen, let's welcome Dr. Benjamin as he will be presenting in this webinar. The second speaker will be Dr. Hupe Mwamba, who's going to talk about community-centered and culturally responsive interventions. Dr. Hupe Mwamba is a senior lecturer in the nursing and midwifery at the University of Notre Dame, Australia, Sydney campus, and a passionate advocate for maternal, neonatal, and child health. She holds a PhD in midwifery, an MPhil in maternal and child health, and advanced nursing and midwifery qualifications from South Africa and Zambia. With over 19 years of experience across Australia, South Africa, and Zambia, she has worked in teaching, research, management, and clinical practice. Dr. Mwamba is also a co-founder of Newborn Support Zambia, promoting quality neonatal care and driving improvement in maternal and child health services. Our third speaker will be Dr. Felix Wondala, who's going to present self-care practices for promoting mental health, including techniques for stress management and building resilience. Dr. Felix Wondala is the Assistant Director for Newborn, Child and Adolescent Health at the Ministry of Health, Tanzania. He is a medical doctor with a master's in health policy and management and is pursuing a PhD in neonatal facility health systems and care outcomes. With over 18 years of experience, he has held key leadership roles, including program officer for IMCI and neonatal coordinator for newborn and child health. He is skilled in policy development, guideline formulation, and technical coordination. His recent BMJ Global Health publication highlights his dedication to improving neonatal care and child health outcomes in Tanzania. Ladies and gentlemen, let's put our hands together as we welcome our first speaker, Dr. Benjamin Kamala, who's taking us through innovations and evidence-based clinical practice. Dr. Kamala, it's all yours.
Hello, can you hear me?
Yes, Dr. Kamala, we can.
Okay, so I was muted. Hi everyone, and thank you for giving me this opportunity to present to you this important work that has been conducted in Tanzania on the Safer Birth Bundle of Care, which is the bundle of care which takes care during birth. It has been introduced. I'm presenting on behalf of the research group that is implementing this bundle. So a little bit of the background. So Tanzania is a population of nearly 68 million. As you can see in the map of Africa, that's where Tanzania is located. And there's 31 administrative regions with a growth rate of 3.2%. The life expectancy is 66 million. But given the growth rate of 3.2, we have nearly 2.2 million births every year. And the neonatal mortality rate is around 20 per 1,000, which is equivalent to 50 newborns dying every year before 28 days. So the background of our work dates back in 2009, where we have conducted several studies, but the focus has been to enhance the midwife and be able to manage the mothers and the newborn on the day of birth. So all these innovations with the $30 million that have been invested with the 20 PhDs that have been completed, including myself. Also, we have 8 PhD, which are ongoing, with more than 150 peer-reviewed papers that have been published, been conducted at Haydom, but also other hospitals, including international hospitals and Temeke in Dar es Salaam. The focus being to support the healthcare worker who is providing the care during the day of birth to be able to manage the mothers and the newborn and reduce maternal and newborn mortality. Yeah, so why do we focus on the day of birth? It's the most critical time because if you look at the literature and the number of lives that can be saved along the continuum of care, all the way from preconception to postnatal, you are going to have much impact when you focus on the day of birth, that's intrapartum and immediately new care. So that's why our research over the past 15 years have been focusing mostly during the day of birth, because that's the most critical time where most deaths for the mothers, fetus in the womb, and the newborn occurs. Yeah, so what is the safer birth band of care? So it has 4 puzzles. The first puzzle is on the clinical innovation, training innovations. And in here, we have developed several tools that support the healthcare worker to be able to manage the mother and the newborn during labor and delivery. So we have the Mama Bessie, as you can see in the first picture there, which is mannequin, which is used to management of PPH. That was Mama Natalia. Mama Bessie is the mannequin that help the midwife to simulate the difficult labor, but also can be used to manage vacuum assisted birth. And in Neonatal life, this is the smart mannequin that helps the midwife to train, but also provide the feedback that after the training, the Neonatal life will provide the feedback to the midwife on how well the ventilation went and what can the midwife improve on. The second puzzle is on clinical innovations, and in here we have developed the fetal heart rate monitor, which is Moyo, which replaces several tools that have been used over decades. But also we have the Neobit. The Neobit is the tool that helps the midwife or the healthcare provider when the baby is born and is baby, then you can differentiate if the baby is alive or dead. When you wrap around the Neobit within 5 seconds, it will give the reading to know if the baby is alive or dead. And then we have the upright. This is used for newborn resuscitation for the baby who is not breathing, and the penguin sucker. So this comprises the second puzzle. Another innovation is local training using the clinical data. So we are collecting the clinical and the training data, and these data we use them to discuss for continuous quality improvement to the healthcare workers. In most of the facilities in the low resource settings, we use this data for administrative reasons, and most of the healthcare workers don't take care about the quality of this data. So we have introduced the culture of using the local data collected for local decision making. And the fourth puzzle is on sustainability, where we support the healthcare worker, the midwife, but also engage the government at different levels so that we can have regular mentorship, but also conduct supportive supervision using local facilitators. So in our training, we have the local champions at each of the health facility so that the cascade of training can continue, but also they could train at the local health facilities using the low dose, high frequency, which is the modality which have been shown to be very effective. So these are the puzzles that comprises the bundle. So specifically on training innovation, so yes, we are using the simulation-based training, but this training is a little bit different because we have like about 5 steps where when you will have the preparation of the materials for simulation, and then you give a brief simulation, and then we run the scenario. The most important step is the debrief, which takes between 15 to 20 minutes. So the healthcare workers will sit around a round table and discuss on how well did they do the simulation and what can they improve on the next time they do the simulation. And they also document this for quality improvement. So all healthcare workers who participate in the training, they document their names, but also they document the whole scenario on what they did. So this is facilitated by the local champions who are the engine of change in changing the attitude, skills, and practices among their colleagues or their peer healthcare workers. So this is the kind of innovation which have introduced in these hospitals and have really worked very well. So this is what I was describing, that the healthcare workers will sit around after doing the simulation. You can see the healthcare workers in the picture. And this condition provide the reflection and the psychological safety, and they remove the culture of blame and shame among the healthcare workers so that they can work as a team. And when they lose as a team. And when they win as a team, rather than putting some blames on specific individuals. Yeah, so simulation-based training, we use the low dose, high frequency, and this has been critical because most of the healthcare workers don't have enough time. So we advocate for them to train either individually, using the smart mannequin, the Neonatal live, and in some of the health facilities, we've introduced this culture that before you start working, you should go and say hello to Neonatal live, that you do the simulation training individually, and then by so doing, you get the skills every day. Yeah, so this is the healthcare workers in one of the health facilities in Tabora. So this is one of the sites there where we are implementing. They are discussing their own data that they've collected the previous week. As you can see, we have the champion who is facilitating the discussion, and then they can put the plans on what they should do next time. And then we do both the training debrief, but also whenever there's any case that is serious or is unique, we also do conduct clinical debrief. So this is the our theory of change, or our learning cycle, that we started the puzzle. The cycle starts with the aim of improve the quality of care. How do we do that? We need the healthcare worker to be knowledgeable. So that's the knowledge acquisition for individual clinical workers. And most of this knowledge is acquired through training, but also in their schools. And when they are in the health facilities, we encourage them to do individual training. That's skills proficient. So in our case, we're using the Neonatal Live, but it depends on the setting where you can have different facilities or different tools. And then we also encourage the team to train in teams, as you have seen in the previous pictures. In so doing, we give them the culture of working as a team in the clinical setting, but also provide some psychological safety and remove the culture of blame and shame. And then after that, when you train in teams, you are more likely going to to retain the skills and improve your clinical care, which will consequently improve the quality of care. So this is our theoretical thinking when we are conducting or we're implementing the safer-based bundle of care. Yeah, so safer-based bundle of care, it was a step-divided cluster randomized implementation study, which was implemented in 5 regions. You can see the 5 regions: Tanzania, Manyara, Tabora, Shinyanga, Geita, and Mwanza. We selected over 30 hospitals collaborating with the government of Tanzania, which are high burden hospitals, but also with a high number of deliveries. So the burden was measured by the number of newborn deaths, but also maternal deaths. Over the 3 years, we are able to manage more than 300 baby mother pairs over 3 years. And then the second phase, we are implementing in 142 hospitals, and we expect to cover more than 600,000 baby mother pairs. Currently, we are having 8 PhD students in this project, 7 in our Tanzania institution and 1 in the University of Stavanger in Norway. So on the results, we have been able to publish 7 papers from this work that we conducted since 2020. But I'm going to present to you a snapshot of the paper that was published in the New England Journal of Medicine in February, which is the main paper on the outcomes of the program of this self-based band of care program in Tanzania. So in this program, so primary objective was to reduce perinatal deaths, and we are able to reduce the death from 15. You can see the x-axis is incidence per 1,000 beds, and then the x-axis is the time. So, and you can see different lines. This was a stepped UHD implementation study where we started with the Manyala, and then after 3 months we went to Tabora, 3 months we went to Geita. And because there was a lot of need for the program, we ended up combining 2 regions, which are Shinyanga and Mwanza. And we are able to, we observed a reduction of the perinatal deaths from around 15 to almost 11.5, which was 18% reduction in perinatal deaths, which was statistically significant. We did not observe a reduction in stillbirth. You can see when we started the implementation, the numbers were very low. And after starting the implementation around the month of November, December in 2021, we saw a sharp rise actually of interpartum stillbirth. And then we conducted some qualitative studies to understand why are we seeing this reduction in increase in death. So midwives reported that at the beginning they are shy and they are afraid of being blamed, so they are not reporting the stillbirth that are occurring at the facilities. But after conducting several, we encouraged them to report because we told them that if you don't report, then you don't get the opportunity to learn from maybe the mistake that you did. So they started reporting. That's why we see the numbers starting to rise in the month of December. But over the course of the whole study, overall, we did not see a significant reduction in interpartum stillbirth. So we also analyzed the 24-hour newborn death. That's the death that are occurring within the first day. We saw from around 7 to almost 4 deaths per 1,000 live births. And this was a 40% reduction in newborn deaths within 24 hours, which was statistically significant across the 5 regions. But what was most striking in our program, which was not expected to anyone, we targeted the reduction of maternal deaths by 10%. But we are surprised by a dramatic reduction from 350 to less than 70 deaths per 100,000 births. So this was almost 70% reduction in maternal deaths in these 30 hospitals over the course of 3 years. So we conducted a qualitative study to understand why did we see this reduction. So midwives reported that at the beginning, they were shy and they were afraid of managing the PPH. So in these facilities, they reported that number 1 cause of death was PPH, almost 70% of death. And most of the midwives were did not have the skills to manage the PPH. But they report that after doing the simulation training, low dose, high frequency, using sim beginning theories and principle whereby they are sitting in groups and doing everything in groups, so they are able to manage the PPH. And actually, some of them, they say that they would wait for a doctor to come before doing anything. But nowadays, they're doing the necessary things that are supposed to be done. So that when the doctor even Dr. Karam, she or he may not need to do anything. But also, if the mother is not well managed, but at least some of the emergency things are being done to this woman. And some of these mothers were actually being referred to other centers without doing anything. But after getting the skills, they say that they are now managing these mothers at their home facilities. So we believe that there could be some other contributing factor, but this was one of the reasons, some of the reasons that the midwives gave. So the full details of this program and this results are available online in the New England Journal of Medicine, and the paper can be accessed using the below link that you can see. So we have also conducted cost effectiveness study, when the study has been shown to be cost effective according to WHO. So what are the main lessons with that co-creation and implementation of innovation critical. Research was taken more than 15 years, but this was a combination between the scientists, but also the healthcare workers. We have conducted several qualitative studies to understand, the needs that the midwife have. But secondly, we need to focus on cost effectiveness and relatively simple interventions. Some of you may have seen these innovations that we're using. They are relatively very simple and very cheap, but we have significantly seen a lot of significant changes in maternal and newborn morbidity and mortality. Research needs to be resilient, so it has taken us more than 15 years, but also we need to target the human resource, the midwife, who is the end user of the technologies that we are innovating. She or he need to be trained, supported, equipped for her to be able to perform well. Use of local data for local decision making is very critical for quality improvement, but also collaboration among partners. In this program, we have collaborated with Lado Global Health, Stavanger University in Norway, but also Global Financing Facility have supported us, given the funding to implement this program. Public and private collaborators, but also professional association have been very critical in the implementation of this program. So the next steps, as I said, SBBC is being rolled out in 142 comprehensive emergency and obstetric care facilities, but we have included other components which are not available in the first phase, as you can see in that chart. But internationally, we are going to scale to other countries. We have also been working with the Nigerian government, and we have enrolled the SBBC in 2 states in Nigeria, Gombe and Bono, under the support of Norwegian Church Aid and Chai Foundation. But also other countries have shown some interest, and we are still working on them. So I would like to acknowledge partners, local and international, as you can see them in this chat. And thank you so much for listening to me. So we say that newborn death, maternal death are unacceptable. So we need to join hands from different stakeholders to make sure that we eradicate these deaths. Thank you so much.
Thank you so much, Dr. Kamala, for that insightful presentation. This time around, I would like to call upon the second speaker, who is Dr. Wope Mwamba, who's going to talk about community-centered and culturally responsive interventions. Dr. Wope, the floor is all yours.
Thank you very much. So building on from what Dr. Benjamin has just given us and looking at joining hands together, one aspect that we need to implement is community-centered and culturally responsive interventions in maternal and newborn care. So this will be my focus as we get through this presentation. Thank you. Okay, so just a quick overview of what I'll go through. I'll look at exploring community-centered and culturally responsive approaches that we can implement. And then we'll look at defining what continuity of care may look like in the African context. And then we'll examine the role of nurses and midwives in community-centered care, then discuss benefits and challenges, and then there will be a presentation of a real-life case example that we have from Ghana, and then we'll conclude with provision of recommendations for action. Okay, so when we're talking about community-centered care, we are talking about having nurses and midwives working in the community. Community may mean a school, it may mean aged care if you have aged care facilities where the elderly are residents. And then it may also mean midwives getting to the communities and being with the women in the process of pregnancy, labor and birth through to 6 weeks postpartum. So that is by definition. And so it is very important to know that uh, we need nurses and midwives to be out there in the communities, even as we talk about improvement in the quality of care, and even for us to be able to meet some of the sustainable development goals. We really need midwives to be out there in the communities. So we need to strengthen this conversation of community midwifery and community nursing throughout. And so we know that by doing this, we can strengthen our community engagement by ensuring that we are having conversation with leaders and even birth attendants that we have in the community, like traditional birth attendants, although we've now shifted into using them as referral agents and not them working as birth attendants like they used to do before. And it is actually very important to ensure that we have resources that are needed, like mobile clinics. And so you just need a vehicle to be able to move from one house to the other. And we need to have a record of the women or the patients that need follow-ups at home. And so by implementing community-centered care, it is just important to ensure that there is community involvement in the planning and even feedback. Like communities need to be giving feedback to health facilities that have implemented communities. So the community midwifery and nursing programs should be a link between hospitals or health facilities and communities so that the nurses and midwives can be able to refer back people that are sick, the people that they have identified to be unwell and needing appropriate care. So it's extremely important for nurses and midwives that are working in communities to be attached to health facilities for continuity of care. Okay, so when we're talking about cultural responsive interventions, we're looking at caring for people using their lens, the lens of their cultural aspects that they consider relevant to their cultures. And so when we're focusing on ensuring that there is consistent and coordinated culturally appropriate care, it entails that we need to have people that are trained in different cultures because we need to embrace the cultural aspects of the people that we are managing because people come to us with their cultures. So all we need is to be able to understand cultural aspects and embrace them
Yes.
in the care that we are providing as long as they are safe cultural practices. And so it's extremely important that we are comfortable in using the local languages. So whenever we are visiting communities, it's very important to be able to use the language that the communities are using, and we need to understand the norms. For instance, there were times when we went for our primary health care activities and community diagnosis in Luangwa district when I was doing my nursing training in Zambia. And so one thing that we were told, like in our orientation, was that when you are offered food, when you go to visit people, make sure you eat it because if you don't eat, it is disrespectful. So we need to understand the cultural norms of the people that we are managing. And so there are certain skills that come with that. So we need to be able to be respectful, and we all need to communicate therapeutically. And it is extremely important to know that in our community work that we embark on as nurses and midwives, we are able to have the skills that are needed with regards to assessments and interpretation of what we're finding. Because community and culturally responsive interventions that we offer are supposed to be a person-centered for people that have chronic illnesses like diabetes mellitus, hypertension, or cancer, because now we have a lot of people that are suffering from cancer, and so those are people that really need the nurses and the midwives to be able to follow them up. When we're talking about midwifery, we're talking about following pregnant women, those that have given birth, and those that are about to give birth, and so on and so forth. But when we're talking about nursing, we're talking about managing people at home, doing the things that we would have done if they were admitted in the hospital. But there has to be people have to be discharged into their homes. But again, there has to be continuity of care, and so the nurses can be able to offer that in the comfort of the people that have been discharged from hospitals. And also, it also helps with enhancement of health promotion activities, and nurses are able to provide the needed support that the patients may need in the comfort of their homes. And so it is important to train nurses and midwives to recognize cultural values and even things that are needed when they are doing their community work. Okay, so when we're talking about continuity care, so remember what I mentioned earlier, where I looked at having people with chronic illnesses and being followed through, as we are supporting them to live a normal life with their illnesses at home. And so this just means that we are providing the care that we would have provided in the hospital, but in the home. And one key aspect that we need to know in the quality of health that we are providing of healthcare is ensuring that patients receive seamless and integrated care throughout their treatment journey, because like once somebody has a chronic illness, it doesn't just end there and then after discharge. It continues for the rest of their lives or for as long as they have the illness. So it is very, very important for us to continue managing them. And so we know that community nursing and community midwifery involves us having and building trustworthy relationships, uh, because once you are in the community, you are living with the people, and so the people that you're living with have to trust you for them to be able to accommodate you in their setting. And so that's why initially I mentioned that it is very important to work with communities. And so in trying to build community nursing and midwifery, it is very important to ensure that in the planning phase of the implementation, we work with communities so that they can know that they are now going to be having people that will be visiting them in the comfort of their homes to ensure that they are living a healthy life with their illnesses. Okay, and so this actually improves outcomes both for the patients, because once you are visiting people on like some days that you decide, like you have to decide how often the community healthcare will be provided to different people. And so once you go there and you realize that because you have to go there with the equipment, the BP machines, the thermometers that we use for checking temperatures, and then we also have to have the skills that are needed when we're talking to people, and just looking at them, you'll be able to identify if there are any issues for early referral to the health facility for further management and all of that. So there has to be that skill up. And so by doing that, we have to ensure that we are mentoring the nurses that will be working in the communities and even the midwives, so that they can be able to have the skills that are needed to be able to make appropriate referrals where referrals are needed, so that we can improve the care to prevent deaths in the communities. Yeah, and so when we're talking about midwifery, we're talking about improvements in the maternal, newborn, and child health continuum of care that we are looking at. And so once midwives are working in the communities, you take note of the women that need to be followed up in their homes, in the comfort of their homes in pregnancy, after labor and birth, like on day 2. And one example that I can give with regards to that is that I work as a neonatal nurse in my casual shifts. And so one day I was working, and the baby that I had jaundice, severe jaundice. And this was a referral that came to the hospital from a midwife that was doing community work. And so this midwife went to this home did the assessment. The baby was very lethargic, not feeding, very dehydrated. First time mom was like, no, the baby has been sleeping most of the time, not interested in feeding and all of that. So the midwife did the assessments and referred back the baby to the hospital, and the baby came in. The jaundice was very, very severe. Like we had to put the baby on 5 lights and all of that. And so within a day or two after the treatment that was instituted, the baby's condition improved, and the baby started to feed orally. And so, we saved their life. So imagine if there was no midwife that went to that house to check on this first time mom, we would have lost the baby. So it's very important to have people, midwives and nurses visiting people at home for continuity of care. Okay, so when we're talking about continuity of care in midwifery, we are talking about this care that is provided to this pregnant woman from the first contact through to 6 weeks postpartum. And so this continuity of care in midwifery has to be implemented in training as well. So the midwifery students that we are having should have a program where they are able to follow women from the time that they meet them to 6 weeks postpartum. And so in training, you need to have the standards, how many antenatal visits that a student should have completed for this one continuity of care. Usually there's a number, so you attach a number to that if it's 4 or 5 and so on and so forth. And then they also need to have the labor experience for it to be a complete continuity of care experience. And then whenever they conduct their labor experience, they also have to reflect on what experience they've gained and all of that. And then they have to have the postpartum visit. So they have to visit the women at 2 days and then at 7 days, and they schedule their visits up to 6 weeks postpartum. So once you train the student midwives, when they get into to their graduate years, when they start working, they are able to implement that. For those that are already working, if they are to work in communities, all we need is an orientation, taking the midwives through what is expected of them. And I know most countries do domiciliary visits during training. And so it's just intensifying the domiciliary type of visits where we are going to be starting from their antenatal period. So you're going to be with the women from the time that you meet them at their first appointment through to the time that they'll be 6 weeks postpartum. And so it builds the relationship, the therapeutic relationships that is needed for people to be able to trust the midwives. And it also has shown a lot of improvements in the outcomes in maternal, newborn, and child health. So these are things that needs to be done. And so the women are able to trust the midwives. They're able to call them when they're not feeling fine, and the midwives are able to get to the communities and be with the women whenever they are called for if there's any issue. And midwives are able to make timely referrals if need be. So this is what we need for continuity of care and for us to be able to attain the Sustainable Development Goals by 2030. So I've already mentioned the roles of nurses and midwives with regards to continuity of care. And so it's just re-emphasizing what is needed. So remember, nurses are skilled people who are supposed to be with people in the setting, in the local setting at home. So when we're talking about community and culturally responsive care or interventions, we are talking about nurses that have already been trained and they are able to see beyond the conversations that they're having when they visit the people that have been assigned to them. And so it's ensuring that they are doing assessments when they visit the people and then interpreting their findings from both their physical assessment and even their observations that they have undertaken. And so it's very important to note that by doing that, they're acting as care coordinators, ensuring that they are able to plan the care with these patients, these women, and the families, ensuring that there's person-centered care that is being provided, thereby improving the health of these people that are being followed up. And it also helps with building of trust because I think many of us can attest to that. People sometimes feel like we don't have that trust between the communities and our professions, being nurses and midwives. And so once we develop things like community midwifery and nursing, we'll be able to build the trust because we'll start those programs together with the communities. So we'll plan together and work together to better the lives of the people that we'll be managing in the communities. Okay, and so yeah, person-centered care is the business of this continuity of care. And so the benefits will include improved patient satisfaction, of course, and health literacy, because we're talking about nurses and midwives being able to provide information, education to the people that they are managing, thereby improving their health literacy, and hopefully the people that they are managing in the communities will be able to improve their health literacy and health uptakes of different services. And so it also builds stronger health systems and cultural alignment. So because we are able to to speak the same language that the people that we are managing as speaking, and we will be able to build those stronger relationships between systems, of course, reduce maternal and newborn and mortalities that may have occurred if there was no nurse or midwife are present in the communities. And so I've already mentioned about early identification and referral for appropriate care and full community participation, of course, because we work together with communities in ensuring that community nursing and midwifery is accepted out there in the communities. Okay, so what are some of the challenges to implementation? I know everybody will be talking about workforce shortages and training gaps. So for training gaps, I can say that it's very easy because people already know what we are supposed to do as nurses and midwives. So we already know our scopes of practice. And so all what will be needed for us to be able to implement this is just orientation on what is expected for follow-ups and for continuity of care when it comes to pregnant women up to 6 weeks postpartum. When we're talking about workforce shortages, I think most African countries have an influx of employed nurses and midwives, and so all we need is to ensure that decision makers are able to open up more paid positions where nurses and midwives can be able to work in communities. We need to have standards with regards to that. So we need to have standards like, for instance, whenever there's a community visit, a follow-up that needs to be done, people, nurses and midwives should be able to go, the two of them, and not just one person at a time, so that if there are any issues, you're able to support each other through that. And so workforce shortages in Africa isn't an issue. All we need is to ensure advocacy so that we can have more paid positions for employment, and probably even starting up our own private practices where we have community nurses and midwives, which is being run by ourselves as midwives. So we need to start up those practices. And so when we're talking about infrastructure and resource limitations, I think it's not much that is needed. It's the basic things, plus a vehicle for you to be able to move from one point to the other. Yeah, and so that can be handled once planning has been instituted. Okay, and so one example that I would give with regards to strategies that have worked with regards to community health planning and services is the Ghanaian Community Health and Planning Service. So this was implemented in Ghana, and midwives have been embedded into communities where they are able to take through pregnant women up to 6 weeks of postpartum. And so this has seen a reduction in maternal and neonatal mortality, and there's also an increase in the uptake of antenatal care because they're in the communities. So they are able to follow through, and people are able to trust the midwives as early as possible because they know that there's a midwife that comes in this area. So the call to action for enhancing community-centered care and culturally responsive interventions include actions by policymakers, where we're talking about an increase in the number of positions, because community nursing and midwifery can sit in the Ministry of Health, and it can be supported by the government. And so we just need more positions, and we need people to buy into the idea. And so the policymakers should be able to support these community-based interventions or models so that we can have continuity of care and follow-ups for people that need continuous follow-ups and for pregnant women. And so enhancement of infrastructure is something that can also be considered. And by this, it's not so much that is needed. We can work on quantifying and putting the figures to what may be needed for a community service to be implemented. Yes, and so we also need to understand that we have to reorient people with regards to culture so that as they go out there, they are able to understand the culture of the people that they are saving. And so we need to advocate for system support and training, and we need to work collaboratively with communities so that we can be able to sustain this community intervention once implemented. And so for healthcare providers, we need to invest in cultural competences training, which can be adaptation, because it's something that is usually silent in most curriculums, but we can add that so that people can Okay, so the last call to action is for community leaders. So we need to advocate for health equity. So once communities are demanding for the care, it actually becomes easier for Ministry of Health to implement strategies. And so this is one aspect that needs to be embraced. And then we need to ensure that they are able to facilitate health education. So once they organize health education sessions and then invite nurses and midwives to go and present to raise awareness in certain areas, that usually helps. And so we also need to have support from, they also need to support local health initiatives, which is something that I've seen working. I once worked with the Center for Infectious Disease Research in Zambia, where we were working in communities of Lusaka rural. And so one aspect that we are doing in our better health outcomes through mentoring and assessment project was involving working with communities to enhance primary health care. And so we worked with communities. We would go into the health facility and we'll have meetings with community leaders. And then we'll also bring in community health workers and traditional birth attendants. And so working together with them in the interventions that we were taking to communities. So once we involve the community leaders, it just makes a life easier because they're able to buy into the idea and they're able to promote our activities. Yeah, so that is all with regards to community nursing and midwifery. Thank you very much.
Thank you so much, Dr. Wupe, for that insightful presentation. Next on the program is Dr. Felix Wundala, who is our third speaker this afternoon, who's going to take us through in the strengthening of health systems for maternal and neonatal survival. Dr. Wundala, you can take it up.
Thank you so much. I will talk on strengthening health systems, a case of Tanzania, and with some examples, I'll be talking the way as a country we have improved issue of infrastructures, issue of equipments, issue of human workforce, issue of the financing, but even the outcome of that, which ended to the good improvement in the impact in terms of reduction of maternal, new and child health. But just to highlight, we are talking of Tanzania, a big country, around 1 million around 1 million, close to 1 million square kilometers, with a population of over 68 millions. We do provide services in public and the private, where the public account for 60% of it, and around 40% is under the private sector. We have the annual live birth close to 2.2 million. Next. In terms of organization, we do have the tertiary hospitals, which there are around 12 of them. We have the regional referral hospitals, which is 28 of them. We have the cancer hospitals, as you can see, 177, and 1,213 health centers. We have the dispensers, that is which are over 8,000. As I said, my focus of this presentation, I'll be talking on issue of infrastructures, where the country in the tune of 5 to 10 years, we have increased very much the availability of these facilities in all types. That we have increased the CMOC facilities from 115 in 2015 to around 566 in 2024. But dispensaries also increased, and but not only that, but also the hospitals. So even the commodities availability, we have increased to the availability of 80% or more. The human workforce also that increased in terms of employment. Just in the past 3 years, we have employed more than 30,000 human resource for health. That have even reduced the human resource gap from 66% to 55%. But again, issue of training, different programs being introduced for the service training, but even for the pre-service trainings, including the masters and the short courses. But again, we have also introduced some in-service competence-based training in kind of mentorship, clinical attachment, to capacitate our healthcare providers. Each of the guidelines and the standard adapting from WHO, UNICEF, but also make sure that it aligns with the country context. Each of the data, but each of the resource mobilization, make sure we are able to finance the different health systems. Next. Next slide. So this some of the outcome results coming from the strengthening of the health systems that currently are around 75% to 80% of the population, they access the health services within the 5 kilometers radius. But in the cesarean section rate, we have seen increasing from 5% in 2015 to a tune of 11% in 2021. We see the antenatal for visit coverage increasing to around 95. This is the difference from DHS 2022. Institution deliveries also increased from 65 in 2025 to 81. But again, even the skilled birth attendant also increased to 85. We see in terms of the under 5, the coverage of vaccination have remained almost constant for years, around 90% or more. But again, in the issue of under 5, we see the treatment among under 5. We talk then the respiratory infection treatment, and that even increases the fever management, diarrhea management. So this number of issues which have improved following the improvement in the health systems. Next. This slide, this slide indicates the progress in maternal impact indicators, under 5 indicators, but where we should be in 2030 when we want to align with the Sustainable Development Goals. So, starting with the first piece, as you can see, maternal mortality stagnated for many years between, as you can see, between 600 to 500 plus. But following the political commitment, following the investment, as I mentioned, the investment in infrastructure, equipment, and in other health systems, that led to improvement of the outcomes I just mentioned. Tanzania have significantly reduced maternal mortality from 2015 or 2016 to 2020, the reduction of 530 to 104. This is a tremendous reduction of around 80% reduction in a tune of 6 to 7 years. But again, the issue of the under 5, as you can see, we have managed to reduce the under 5 mortality from 67 in the same year, and mentioned about 2016 to 43, which is also around 37% reduction. But also the infant reduction. Okay, come again. The infant reduction, as you can see, that's reduced from 43 to 30. This is per 1,000 live birth. The only problems is within the neonatal mortality reduction, as you can see, have remained high and stagnated for years, just reducing by 1 from 25 to 24. And if we count the Tanzania annual live birth of 2.2 million, this is equivalent to around 58,000 newborn a year, maybe, which can be also equivalent to 145 a day. But we all know, even if we say that we have reduced maternal mortality, but we understand we need to sustain the gain, and the gain in maternal mortality, but the gain in child mortality. But we need to innovate or to invent innovation to make sure that we reach sustainable development goals, where we are targeting the maternal mortality of less or equal to 70 per 1,000 live birth, neonatal mortality of 12 per 1,000 live birth, and the under 5 mortality of 25 or less. Next. One of the stagnated indicator, as I mentioned, was neonatal mortality rate. Some of us know in September 2019, WHO and UNICEF recommended reducing this by half. Countries will need to do one, to do essential newborn care to every newborn, but the provision of level 2 care. And the level 2 care essentially means that having a special ward, special neonatal care units for the newborns, and providing management of respiratory distress, including use of the CPAP machine, but managing the jaundice, managing infection, issue of the feeding, and the like. So when we did a simple analysis in Tanzania, I remember this was in 2018, we realized we had only 14 hospitals had neonatal care units. So we did an advocacy to the leaders, including the president, whom you see he's within the neonatal care unit, Her Excellency Dr. Samia Suluhu Hassan, and herself argued to all hospitals that should establish the neonatal care units immediately as possible. And this one have helped the Tanzania, as we are talking the last December, that have increased the availability of neonatal care units from the 14 in 2018 to a tune of 318. And most of these, they are public owned. We have the 28, the regional referral hospitals, 174 in the council hospitals, and the rest are the FBOs in the private. But after we innovated, after establishing these neonatal care units using the available resources, we realized some of the facility has inadequate space. So we went back and do the expansion of of some of the established neonatal care units. And as I'm talking, we have already expanded like 61 neonatal care units. But again, we have the plan to build the new uh, the new neonatal care units in the regional referral hospitals in the some of the district hospitals. As I'm talking, the country have is I think is going to use around like 100 Tanzania billions, which can be maybe equivalent like to 40 million US dollars. And this is going to build in the regional referral hospitals, 15 of them, district hospitals, which will be 20 of them. And we basically now continue to plan to expand the CMOC facilities, because one of the challenge we realized when we build these CMOC facilities, as I mentioned, the increase of 115 to 566. All these CMOC had the theater for the obstetric complication, but we did not consider the care of the sick and small newborns after the labor. So we have to go back and make sure that we have the space to admit the newborn that is well equipped with the equipment, including the CPAP machine, to manage the level 2, to provide level 2 care, as I mentioned, with the competent staff, with in terms of number, but of the quality of care. Next. Next slide. Yeah, so this essentially the core of action, but it is the next step. Number one, as I said, we need to sustain and expand cost-effective intervention that have enabled us to achieve that tremendous achievement in maternal and under 5 care. But number two, we strongly prioritize the newborn care as the number one priorities now, so that we cut half the current neonatal mortality we have by 2030. So we make sure that the essential newborn care is being provided in all levels of facilities that is providing deliveries. But number three is making sure that the level 2 newborn care is available in all hospitals and the CMOC facilities. That we have the neonatal care units with adequate space, with admission bed, and also encouraging even the zero separation. And here I'm talking about the baby mother pair. And number 5, as I said, you have to sustain the gains in infant and under 5 so that we continue improving the well-being of the under 5, but to continuously reduce the under 5 mortality. That is the end. Thank you for listening.
Thank you so much, Doc, for that wonderful presentation. Team, you can see what Tanzania is doing, and that's the whole essence of us coming together and seeing what our colleagues are doing and buying into the ideas of what our colleagues are doing. Thank you so much once again, Doc. Okay, so we now have come to the question and answer session. Please, you can unmute yourself and post the question. If not, you can post in the chat box. We'll be able to read out your question. So I can begin with what is in the chat. Just Bengezo is asking that in all hospitals, how many hospitals? I'm sure that is the question that is directed to Dr. Wundala. Someone would like to know how many hospitals you are dealing with. Dr. Wundala.
Thank you so much. In this country, we have around 400 hospitals, but out of that we do have like 220 this year public owned hospitals. So and the public owned hospitals, they're also organized in different levels. We have the zonal hospitals, we have the regional referral hospitals, and we have district hospitals. All this one, the public owned, they should have the neonatal care unit with a different approach. Number one of approach is improvising, that using the space available to make sure they allocate the neonatal care unit. That one have already done. That's when I was mentioning that 318 hospitals have established NICU. It was within that all public hospitals plus the faith-based organization and some of the private hospitals. So the word "all" usually focuses in public hospitals and the faith-based hospitals. Also, regardless of the different ownership, as the government also goes in private-owned hospitals to assess and see the status and encourage them, despite of having inadequate space, but they should allocate a place to take care of the newborns even before they refer to another stage.
Thank you so much. Is there anyone with a question? That was the only question in the chat. Okay, so silence means consent. The presentations that were given to us this afternoon, I think were loud and clear. And it's up to us to take a leaf to what our colleagues are doing and to collaborate with them so that we learn more of what they are doing so that we help ourselves. There was a comment in the chat where a colleague from South Sudan was saying that the mortality rates there are quite high, and the presentations that were made earlier on would be so much of help. So please, let's collaborate. That's why we are together as a community, so that we learn from one another. At this point in time, if there are no questions, I would like to call upon Madam Lemi Mabonga, the ECSACONM Senior Program Officer, to give a vote of thanks and close the meeting. Madam Lemi, you are welcome.
Thank you so much, Madam Brenda. And thank you, team, for participating in this very important webinar. We know as the region, we are still facing the maternal and neonatal mortality, but listening to the experience from each other's country, I think we'll borrow the new innovations to our country and improve the services. Nurses are everything. You are the front line. So if nurses have the skills and capacity to save lives, it means even the neonatal death and maternal death will reduce. And for now, I would really love to thank the panelists for the good presentation, the informative presentation, but I should also thank our moderator. You did a good job. And thank you so much. We have monthly webinars. Please don't miss. We provide certificate with the CPD points. Thank you so much. And let's meet for the next month webinar. Bye for now. Back to you, Julius.
Yeah, thank you, Lenny, thank you, team. We really appreciate your presence, and we will just share the certificate for those who joined directly from the IECO, as we can retrieve your information. And we really encourage the participant to make sure that you join via the IECO platform by creating your account there so that you can be informed about the coming webinars as well as participating in the discussions after and before the webinar. Thank you so much and bye-bye. Let's meet again the next time.
Thank you.
Thank
Thank
you.
you all.
Thank you. Bye-bye.
Thank you. Bye.